serve don't have any healthcare insurance.
You got to give clinics that work with these populations time and resources to really improve the quality of care and not expect the same time frame and the same amount of resources to do this.
Researchers, policymakers need to understand that there are these special circumstances, situations that we're dealing with the patients that we're taking care of.
My name is Kurt Hall and I'm 54. I drove a truck for 23 years. That's all I ever did. When I got into my late 40s and early 50s, I started having health problems that just completely turned my life upside down. I lost my job. I lost my health insurance. I eventually became homeless and I had no resources. Some friends of mine said, well, go down to Old Town Clinic. And so I came down and Dr. Rachel Solitroff became my primary care doctor. They are very passionate about the job that they do. They're very serious about it and they changed my life.
My name is Susan and I'm 43 years old and I've been an addict for 32 years. I lost my dignity, I lost my teeth. I had no respect for myself. Someone briefly told me about this program and I can say that I have my own apartment today. I have my family back. I have my son's respect and he tells me, I love you today, Mom, for doing what you're doing. I'm a miracle today. I'm a survivor. I'm who I am today because of this program.
My name is Alice Tucker. Found out I had COPD, bronchitis, emphysema, and chronic asthma. And with the help of Rachel and people at the program, they work with you. They really give you chances and help you get housing, medical, whatever you need to keep you off that streets, they will do that for you. I transformed into a grown woman, actually, a more responsible adult.
Homelessness, criminality, lack of employment, lack of education, addiction, chronic mental illness.
You're trying to get all these visits to the door to make your budget ends meet, and then you're doing all this other service which is really more helpful to the health status of the patient, and that's non-billable.
The problem with our system now is that the way the day is divided up, it's still in 20-minute increments. Even if it makes the most sense for me to spend 2 hours with a patient focusing on a very complex medical condition, we can't do that. I still have to truncate that 2-hour visit into 20 minutes so I can stack up all these other visits.
Right now, healthcare kind of works on this widget production model where you're paid for a primary care provider to see a patient face to face, and that's really the only thing that gets paid.
One of the beauties of this clinic and of this agency as a whole is that the needle that we're always trying to move is hospitalizations and emergency room visits. And it's been shown by lots of research that communities with strong primary care systems avoid hospitalizations as well as emergency room visits, so that we eliminate waste, eliminate redundancy.
What's lacking is the definition of how are we going to reform payment so that these clinics can really provide the quality of care to the patients that they need.
Patients who are served by the safety net present specific challenges, and we need to figure out how to make sure that our quality metrics understand those and make sure that we use the data in a way that respects those differences.
I would just like to have a more thoughtful dialogue about how are we making people healthier, and let's measure the things that are really helping to improve people's health.
We really want to push on a payment system that rewards good quality care, and the assumption is that the data will be there to do all of that. And in fact, we're still at some pretty early stages. It's going to take us a little while to get where we want to be. That doesn't mean we drag our feet. We can get started. We just need everyone to come to the table and be very thoughtful and collaborative about how we use data to really drive the kind of change we want.